Hello, everybody. Good morning, good afternoon, and good evening, depending on where you're joining us from. We can see that you're coming in. If you want to, as always, you may use the chat function to let us know which country, city, or state you're joining from. We are delighted to welcome you to our webinar today titled Medical Interpretation for End of Life Issues, a very delicate, sensitive, but critical topic. Okay, my name is Analia. I am the manager of training and curriculum here at Cross Cultural Communications, one of the leading US training agencies for medical and community interpreting, and creators of Blue Horizon, our online learning platform for our self-paced and live training programs. I will be your host for today's 1-hour webinar. Also with me is my colleague Andrew Hall, Cross-Cultural Communications Publications Manager. Andrew will manage the chat and will provide useful information throughout the webinar. He is incognito, but he's here with us. Okay, before we begin, and as we wait for everyone to join, to come online, I would like to share with you the upcoming fall training schedule, which is available on our website. Andrew will share the link for each training session. And as I mentioned them, please remember CC operates in Eastern time zone. Okay, here comes the first one. Interpreting for forensic evaluations using a trauma-informed approach. This is coming on Saturday, November 23rd, with instructors Dr. Robin Reagan and Dr. Jordan Greenbaum. Note that there is only one seat left for this class. If you really want it, you might want to go right now on the link and join. Okay. Second of all, we still have seats remaining for our live session of the Community Interpreter 40-hour foundation program. This will take place on December 16th through the 20th, live on Zoom. And the trainer will be me. So, hey, we're going to have a blast. You know, if you're interested, please join us and check it out, of course. Okay, looking into the future, going to 2025. We have two upcoming courses. We have the medical terminology for healthcare interpreters. This 8-hour intensive workshop is a must-have for interpreters in healthcare settings. And this is led by the amazing Cindy Roth. And our TCII TOT, the TOT trains and licenses interpreters to deliver the Community Interpreter International Program. The spring cohort starts on March 17th and ends on April the 4th. Okay, let's go over a few points regarding the webinar, right? The webinar presentation will last around 40 to 45 minutes, followed by a 15 to 20-minute Q&A period, during which you can ask our presenter questions. During the webinar, please keep the Q&A feature open and use the Q&A to submit your questions for our presenter. For other comments or questions for us at Cross Cultural Communications, please use the chat feature instead. And if you want everyone, right, to see your comments in the chat, please make sure that you set the chat function to everyone. Lastly, if you want to stay on after our presenter leaves at the end of the hour to chat with Andrew and me, we will be happy to answer any questions about both cross-cultural communications and Blue Horizons. A few more things as a reminder, this webinar has been approved for CEUs. I know that's important for all of us as interpreters. Please remember, 24 hours after the webinar, attendees will be emailed a link to download a certificate of attendance. It will go to the email you used to register for the webinar. Please check your spam or junk folder if you don't see it. Certificates are only available for attendees of the live session of this webinar. They must be downloaded within 3 weeks of today's session. This time frame is different from what CCC has done previously. Please, people, please, you are my people, my community. Remember to download your certificate as soon as you receive it. Okay, now, without further ado, let's begin our webinar title, Medical Interpretation for End-of-Life Issues. Our presenter today is Dr. Eric Hardt, and I am so excited to tell you about him. Dr. Eric Hardt was a primary care geriatrician in Boston, Massachusetts, and has over 48 years of experience in the medical field. He graduated from Tufts School of Medicine in 1974. He's affiliated with Boston Medical Center. Currently, Dr. Hardt is retired, and he was awarded the Tony Windsor Award at the 2021 Massachusetts Area Health Education Centers Paving the Way to Healthcare Access Conference. Eric is the co-author of Critical Research, some of the first of its kind, showing the financial cost and clinical consequences of language barriers, and demonstrating the difference in error rate between an ad hoc and a professional interpreters. Dr. Hardt used his position to give recognition and credibility to the medical interpreting field, which was instrumental to the passage of state laws, institution-level policies, and culture change. Ladies and gentlemen, without his contributions, relentlessly over decades, many more LEP patients would still be relying on their children or receptionists for interpretation. We are delighted to welcome his expertise to this webinar. Welcome, Dr. Hardt. Please take it over.
Thank you, Analia. It was a long description of me. The important thing is that I've been working with medical interpreters since 1985, when they were all in-person, full-time employees of Boston City Hospital, working for the nation's first full-time director of interpreter services. And that's why I'm very passionate about thinking of interpreters as professional members of our team, just like nurses and social workers and physical therapists and everybody else. It's a matter of time, hopefully while I'm still alive, that training already is everywhere and certification is becoming more common. Eventually licensing will be required, and then you'll all get a large increase in pay, like us licensed professionals do. And old men like me tell stories very briefly. At the end of seeing a Somali patient, as I was ready to leave, my interpreter was having a chat with the patient, then they held hands. When I asked him what was going on, he said, "She told me that she had an application for food stamps and she couldn't figure out how to fill it out. I told her to bring it in next time and I'd help her do it." Period. That's a somewhat expansion of a role, and I'm thrilled with that, and hopefully we'll see it more and more. All right, I apologize now for talking fast and going through these slides very quickly so we'll have time for questions. You've all seen the educational objectives, difference between hospice and palliative care, the difference between advanced care planning and healthcare proxies. We're going to look at the paperwork very quickly. The interesting and tricky thing to talk about is proper communication techniques. And I think if we had a in-person weekend retreat, we could probably talk about all of these things as needed. But we're going to move on very quickly. Geriatrics in America, at least, is a growth industry. Us baby boomers, all the babies born after World War II, we've stressed everything when we went to school, college, when we got married, had kids, when we retired, and we're going to do the same thing when we're getting ready to die. So here's the numbers in America. Both foreign-born and native-born Americans The percentage of patients of people over age 65 has gone up by a third in 20 years to 2020. In the next 20 years, well, by 2040, it's going to double again, and people over age 60, over age 85 will quadruple. So what I'm saying here is that some of you eventually will get certified as a subspecialist, like I did, geriatric medical interpreter. And I want you to know what we want you to know. I want you to know the physician's point of view, what I'm trying to figure out, what I'm trying to explain to the patient about specific issues that relate to the elderly. We're going to need more and more and more interpreters who are familiar with things like falls and dementia, incontinence, and end of life. That's why we're talking about this. And yes, the medical profession takes this seriously in America. Here's the most commonly read medical journal in America, the Journal of the American Medical Association. And here I was thrilled to see an entire edition about death, dying, and end of life, including articles, for example, about families of Medicare cancer patients who are happier with early hospice referral, less time in the ICU, and more likely to die at home. And very interestingly, a research letter on the other side showed that doctors are the same. We're happier without dying in the hospital or the ICU or in institutions like nursing homes. We want to be home with our family and our food and our music when we pass away. So this is becoming the norm in America. Now, not every person is unique. We are all, each patient is unique. Yes, we're all different in many ways, and deaths are different. If your son gets shot dead at school with a gunshot wound or a motor vehicle accident or an overdose and dies abruptly, that's nothing we're going to be talking about today. I don't think that's anything we can prepare for. God forbid. That's only something we can prevent. Second most common cause trajectory, I would say, about dying is for a disease like ALS, amyotrophic lateral sclerosis. When we make the diagnosis, we know we can't cure you. We can't even slow down the progression of the disease. So we just care for you as you go down that hill until you pass away. Far and away, the most common trajectory of death in America right now, and it will increase, is that thing that you see in the corner, this choppy crisis, not full recovery, crisis, not full recovery, crisis, not full recovery, et cetera, to death. Things like heart failure, chronic lung disease, dementia with its complications, et cetera. This is the kind of thing we're going to be talking about for the rest of today. This is the old-fashioned version of palliative care, we'll call it. As a former oncologist, we'll try to cure you, we'll try to cure you, we'll try to cure you. And then people might say things like, oh, sorry, there's nothing more we can do. We leave, the social worker comes in and starts doing palliative care. And then after the patient dies, we look for family who look very saddened and depressed, and we work on bereavement. This used to be considered normal by the American Medical Association, but things have changed. Thank God. Now, I told you I'm going to tell stories. Here's one. This really happened. I was on the palliative care consult team. We were called to the ICU for a family meeting. Well, not the ICU. We were called to the ward for a family meeting for an elderly Polish-speaking woman with severe heart failure due to aortic valve problems. Her several family members were there, different generations, different levels of English. And we were told that hospice was being considered because the family/patient had declined the major surgery required, they thought, for aortic valve replacement for fear of pain, serious complications. And the patient was supposed to just go home, to be kept comfortable, and die. But with the palliative care consult team brought in a professional Polish interpreter, and accidentally we brought in a cardiac surgeon. We listened to the family as usual. We let them ask questions and responded as usual. And then when it was quiet, we would tell them that we'd like to speak directly with the patient. I've never had a family that said no to that. And basically when the surgeon explained the new technique in replacing the valve. It's one that you see on TV now. It's become very common, that it's much less invasive. You don't have to crack your chest open. You just go in through an artery and you go home in 2 or 3 days. And the patient in Polish, through our interpreter, said, "Oh my God, is it too late for me to have that?" And of course it wasn't. She had that kind of surgery. She went home much better. Without the presence of that professional Polish interpreter at that family meeting, she would have gone home to die peacefully as a hospice patient. The new way of thinking about palliative care is this complicated slide here. We diagnose a problem, we try to cure it, we try to at least extend your life if we can't cure it. And palliative care is really in the background, helping treat symptoms, maintaining function, and maybe bringing up issues like end of life EOL, like do you have a will yet? Have you done that kind of paperwork? Can we help you with that? As this goes on and the patient gets worse and worse, and they get to the point where their life expectancy is 6 months, now it's appropriate, it's acceptable for them to be referred to hospice. We're going to talk about the difference between hospice and palliative care. And the last thing I'll say is we now realize that bereavement starts before death with anticipatory grief, and particularly with hospice or palliative care consultation. We start helping the family deal with that and letting the patient see that their family is going to be okay when they pass away. Much better than the old one. There's nothing more we can do. Here's the National Health Care, Hospice and Palliative Care Organization definition of a hospice. It can be a location or an organization takes care of patients in the last phase of an incurable disease, and they focus on living as fully and comfortably as possible, quality of life and symptom treatment rather than keeping you alive as long as possible. It's interdisciplinary care, and as we'll talk about in a few more minutes, your life expectancy has to be 6 months or less. And the good thing about hospice, when it came to America, we started to realize that everybody dies, and death is not always a failure if you can help a family and patient get a quality death or what they think of as a good death and deal with the bereavement period. In the United States right now, a hospice can be a place where somebody goes to spend their last days. Interesting now, it's spreading all over our country. The Veterans Administration hospitals have hospice beds right there on site. You can get hospice care in a nursing home. And I was delighted to find out some of our prisons and shelters for homeless people can provide hospice in those locations, even for people who have no money and no insurance. I was thrilled once when I had a homeless man, alcoholic, dying of liver disease, who went to a shelter, and I was a hospice medical director, and the shelter was absolutely willing to provide hospice care for him in a shelter for the homeless. It can be an organization or a program. A lot of them are becoming for-profit institutions. We don't have time to talk about that. Sometimes an institution like the Boston VNA also has hospice capability, so you don't have to change the organization you work with. And then, of course, and as everything in America can have to do with the system of reimbursement, your health insurance and whatnot. And we're going to sort of skip the politics of that. To be eligible for hospice, you have to have the life-limiting illness. The life expectancy, 6 months or less. What does that mean? Now, remember, it's an average. When our former president, Jimmy Carter, went on hospice, he's still alive over age 100. He's still on hospice for 18 months. So some people are now considered surviving more than 6 months on hospice is fraudulent and inappropriate. You should be off hospice. But Jimmy Carter has showed us that that's not true. His wife, Rosalind Carter, by the way, went on hospice as she was preparing to die at home. She was on for 2 weeks, and that's okay too for both of them. So in hospice, you can't be trying to cure the patient. You can't be giving them chemotherapy or radiation to try to prolong their life. You have to have switched only to palliative care. And the family, you can't do this without telling them. the patient and the family have to be told. And we'll talk about cultural issues later on, something called the secrecy dilemma. And in America, the young doctors think that you're required to tell the patient that they have cancer. And I tell them, no, the patient is required to have the right to know. So if you ask them questions, what else can I tell you? What else would you like me to explain to you? If they say, I'm okay, my son is the best, he knows everything, he takes care of me, explain it to him, then we can accept that and make sure the family is aware of the diagnosis and prognosis. And always when we see the patient, what new questions do you have for me? They always have the opportunity to ask, that my family doesn't tell me this, doc, am I really dying of cancer? And we can share a conversation with them. Cultural issues are the trickiest stuff that we don't have time to talk about today, and it's the most valuable stuff. And I like the fact that a doctor has to order hospice. You can't just be the family looking it up online and ordering it. Now, we're going to talk about the differences between palliative care and hospice care. Think of hospice as a portion of palliative care. Palliative care is bigger, has a lot more stuff. Hospice is included, but we'll talk about the differences. Here's the World Health Organization's definition of palliative care: multidisciplinary approach, not a place or an organization. Your hospital can start a primary care, palliative care program without a new organization or a location. It looks at quality of life, patients and families, the same way hospice does, prevents and relieves suffering of pain, physical pain, but also all types of problems: psychosocial, logistical, financial, and spiritual. All of these can be addressed if patient and family would like them addressed with palliative care consults. That's why I love being a palliative care consult. The difference between hospice and palliative care: hospice has to be less than 6 months anytime during the illness for palliative care. Only symptom management for hospice. You can be trying to cure the patient while they also have a palliative care consult, helping them with other things. You're not supposed to do labs or x-rays on hospice. You can do it on palliative care. And palliative care is usually right now for an inpatient, like we just saw. Some clinics are opening up, and it would be nice if a palliative care team can make a home visit or a visit to a nursing home to an elderly patient. Now, interestingly, here's a review of literature on palliative care intervention, and these were early studies, and it showed that when you have a palliative care consult, like my team involved, there's improved quality of communication. Now we're just talking about all patients, not patients with limited English proficiency. There's better documentation of what the patient and family wants. The family's more satisfied. The pain and other symptoms are better managed. The physician is responsive to all sorts of needs of the patient and family. Higher satisfaction for the family, the patient, and the medical team. And the thing that got a lot of attention with early palliative care consults: less time spent in the ICU, intensive care unit, and lower cost overall to the family and the taxpayer. And the biggest surprise was that people thought you went on palliative care, that means they're going to speed up your death. Well, actually, not necessarily. Here's one of my favorite studies at Mass General Hospital with lung cancer patients not cured, getting on very aggressive chemotherapy, and they randomized patients to either add palliative care consult or not and get the same exact therapy at Mass General. And what they found was a big surprise. The patients with palliative care were less likely to be getting toxic chemotherapy in the last 2 weeks. And the patients with palliative care lived longer than the other group. They lived 23% longer. So if we had more time, we could talk about how that happened, but it sort of is a way of telling people, not only do you live better toward the end with a palliative care consult, it does not necessarily shorten your time with us. Now we're going to talk about LEP patients and families, and we'll focus on cultural variations in things. Now, you all know about intergenerational conflict, the trickiness of choosing the words that to convey the meaning to patient and family instead of just the word that the clinician picks. Role conflict for the interpreter happens all the time. And we'll talk about, to show an example, so-called what's called breaking bad news. We'll talk about hospice referrals, and we'll talk about something called advanced directives, which basically is how the patient can basically explain to people what they want and what they don't want as they approach, if and when they approach end of life. And that's different from the so-called healthcare proxy. We'll go through those details. And again, our cultural variations in determining a patient's wishes are so complex. That would be another 8-hour discussion with all of you. Now, here's my second story that really happened. Haitian woman in the intensive care unit with a breathing machine, intubated. She was intubated several times before. She's on oxygen at home, so she's used to the ICU intubation. And again, the ICU team was taking care of her. They thought she was doing okay. They wanted to try to get the tube out, but they weren't sure if they might have to put it back in if that didn't work. The patient was awake but intubated, so she couldn't talk. But if you asked her simple questions like, are you in the hospital now? She could shake her head yes. Are you in the library now? She could shake her head no. This is if you ask those questions in Haitian. The palliative care team, again, our consult arrived with a trained interpreter, and we did it the right way. The son was there, and the ICU team had gotten all of the communication was with him. He was the official healthcare proxy. He was a nice guy who loved his mom and wants everything done for her. When we got there, we talked to him, thinking of him again. He's a son. Let's see what a son thinks about that, how a son feels about that. And then after we were done listening to him and answering questions, we told him that we needed to communicate directly with his mother. And we started asking questions. And the bottom line was, through my Haitian interpreter, I explained that the team was going to remove the breathing tube, but they might have to put it back in. And they wanted to know if that was okay with her or not. And she looked at her son and she shook her head no. And her son looked at her in the eye and shed a tear and said in Haitian to her, okay, Mom, we're going to do whatever you want. We'll do it your way. So here's an example of a patient who might have lived the rest of her life in an institution, with a tracheostomy on a breathing machine, but she was allowed to choose the way and location where she was going to die, and she was able to go home to spend her last days with her family as a hospice patient. Here's a relatively recent, by my criteria, 2018 is relatively recent. This was an amazing study of many, I think it was almost 30,000 patients with approximately 3% who were LEP. And if you were LEP, when the study was done, you were less likely to do what she did, change your code status from what we used to call full code, do everything, to do not resuscitate, DNR, which meant basically do nothing. LEP patients less likely to have advanced directives. We're going to show you the paperwork, more likely to be on a breathing machine, more likely to be tied so they don't pull the tube out, more likely to spend longer time in the hospital. So there was an agreement in this study that there are important differences in end-of-life care when patients and families have limited English proficiency. This was an interesting study. It was a qualitative survey of ICU teams, including doctors, nurses, and interpreters. And they felt that there were key differences in the decision-making conversations with LEP patients and family, including the fact that clinician communication was less frequent, that the patient and family understanding was not as good, and the clinician's ability to detect whether or not they understood things was not as good. Relationship building, which we need in medicine. Your practice of medicine doesn't work unless the patient and family trust you. In these situations, relationship building and trust was not as good. And the treatment limitations were often looked at by the healthcare team as not appropriate, not how we like to do it, how we do it now in America, better than you do it in your country with your culture and your customs and your religion. And this is what that team thought, and this is what they thought would help the situation and make things better. Having interpreters and clinicians have pre-meetings before these family meetings we talked about, making sure that interpretation communicates empathy and caring. There's some studies that show that some doctors think it's their job to communicate empathy, that the interpreter not only doesn't have to do it, but shouldn't do it. They should not be the one to take over the caring relationship. These teams thought there should be bidirectional communication of cultural perspectives, which would mean the interpreter explaining to me what a Arabic-speaking Muslim woman would think about the situation, and then we explained to her and the family what modern American medicine tends to do in this situation, so we can figure out what happens in between. And before, in these pre-meetings, we could talk about the kind of words that we're going to use. And the teams felt that cultural humility on the part of the doctor. And when they say clinicians, I'm always thinking about doctors. I've been a doctor for 50 years. That's what happens to you. We need to be more humble when we hear the way people want things done in other cultures and other countries. Here was a systemic review of 10 studies, and the bottom line, it showed that these were all with cancer patients getting palliative care, and the bottom line was, I'll skip right here, the patients had poorer quality of end-of-life care and less, basically, poorer quality end-of-life discussions if professional interpreters were not used. 10 studies. So 2016, almost 10 years ago, we started to realize that when you have a professional interpreter on hand, things can be improved in all the things that we listed. I need to take a rest, and I'll show you a little. This was a patient who came out of the hospital, was referred to our home care program. He had had cancer for surgery, and it didn't really work well. The first time I saw him, I went to the house, and his son interpreted for me. He had shaking tremors, and this time when I went out there, it was to explain how we were going to change the medicine to get rid of this tremor. I was with a social worker from Cape Verde who agreed to make a home visit with me and interpret. Oh, look at that handsome guy.
The doctor is on a routine home visit to a patient who speaks only Cape Verdean Creole. He is accompanied by an interpreter who is also a native of Cape Verde.
Sometimes he feels good, other times he doesn't feel that good.
This month we'll change some of the medicines, and we'll see if this shaking gets better.
Mr. Gonzalez is 70 years old. He was operated on for stomach cancer 1 year before this visit was filmed. The surgeons were unable to remove the entire mass.
Last time we were here, we talked a little bit about what he thinks should happen if he has new problems like he had before. If he's continuously throwing up, for example.
Shortly after the operation, the patient was told that the tumor was not completely removed and that his prognosis was unclear. But only during this visit did he really seem to understand this.
But he understands that his tumor is still in place.
Nós sabemos tumor que nós tem ainda está no mesmo lugar.
Ainda está ali?
Sim.
Quem tem ou quem tem ainda?
He's asking if it's the tumor he had or if it's he still has it.
He still has it.
O doutor falou manhã ainda tem. Manhã tem aquele tumor ainda.
Que tumor é que atacava então?
He's asking if the tumor doesn't go away.
We don't expect that it will go away, although it seems to be quiet.
Doutor falou e que te espera aquele tumor te desaparecer. Embora que se te incomodem tanto e que se te aparecer. E que te acaba.
Então que te fiques saúde.
Then my health won't come back
Então
I won't feel
fiques
healthy.
saúde.
Anymore.
I don't think we expect it will come completely back.
Doutor Flama, saúde de hoje é que te espera e te volta.
Saúde. Mi se spera melhor com saúde agora pelo Francingo e aquilo que triste sengo.
I was expecting to improve and now you're telling me that I won't improve. That makes me feel sad.
Eu tenho coração sabe dia só triste.
My heart is always sad.
E digo-te, mas não tinha tempo. Tanto que estava com o corpo caído, mas agora de virar bom.
Então que você saúde.
E que forma que estava a maybe mabu.
Operação que eu estou aguentando, operação mas.
I can't stand another operation.
É operação maior que faz. Maior.
It's the biggest operation I've ever had.
Okay. So I need to know that, so that if that is ever a decision that he can't tell his doctors, I can tell them what he said.
All right. Analia, any hot questions or comments at this point yet? I can tell you what this man did once he found out. His son had interpreted for the surgeon, by the way, including the consent form, which now the lawyers would not accept. He went back to Cape Verde, took care of some business, picked out a burial ground next to his first wife, came back to America, passed away as a hospice patient at his home with his family, with a parade of community members outside of his house. Without that profession, well, she wasn't even a professional interpreter. And I could ask the question, do you think the son did an appropriate job of interpreting? And did that social worker do a perfect job of interpreting?
Yes, Dr. Hardt, we'll have you continue since it's already 12:08 and at 12:15 we should have more questions. So I just want to encourage everybody, if you have any questions for Dr. Hardt about the video, please go to the Q&A icon and put your question there. Okay, please continue, Dr. Hardt.
Okay, I'm checking on time now. All right, try to speed things up a little bit. Some interpreters, when they see this, they say, wait a minute, she should have interpreted for the doctor what the family was saying to each other. Why didn't she do that? And I thought about it and I said, I realized she had good instincts. She realized if she started interpreting word for word what the family was saying to each other, they probably would have stopped talking. So instead, she waited till they were done and gave me an appropriate summary. Interesting, very recently, May of this year, here was a medical journal from the Cleveland Clinic where they had an article about, this is for doctors, telling us what we need to do to care for patients who want to die back in their home country. And that was amazing when I saw that the profession is taking that seriously. So we could spend an hour talking about that, but I want you to imagine, what if you were the interpreter on this home visit and the patient went back to Cape Verde and found their old doctor there who's going to take care of them and set up a Zoom call with you and me and the patient and the family and the doctor there. So that patient would be seeing an interpreter that and a doctor that he already knows and trusts from back in America. I think I would pay you overtime if you were available to do that kind of international Zoom call for me on a patient that we already had managed together. We're going to have to speed up here. In America, when this book came out in 1969, it became the sort of standard way of thinking about grief in America. 5 stages: denial, anger, bargaining, depression, acceptance. They don't always go in that order. The timing is different for every patient. And here's what we're talking about. Denial, like when people say, wait a minute, that's not right. They want a second opinion. They think you're wrong. Or they get mad at each other and at you. They start yelling. Don't suddenly stand up and say, stop. Don't do that. No yelling. Let them ventilate. Help them stay in control. Don't let them fight with each other. And when things slow down, you can jump in with something like, this must be very hard for your family. If you want to bargain and help them figure out what's going to happen, let them talk, listen. It's hard to convince doctors that they have to listen half the time. And ask open-ended questions. When a doctor says, do you have any, stands up from his desk, looks at you and says, do you have any questions? That usually means I have to leave now, goodbye. And the answer is almost always no. What if the doctor said that, let's say a young doctor in a rush? What if the medical interpreter turned that into a question, what are your questions for Dr. Hardt? And the patient then starts talking with 2 or 3 important questions. In my experience, the doctors with interpreters like that will find me and say, wow, Eric, what is that new interpreter? Where'd you find her? That was the best I ever had. Although some people would say that's a violation of your code of ethics. We don't have time to talk about that one either. Depression and sadness, of course, is normal. And as you saw there, silence, pauses, eye contact, affective posture, all are just as important as the words. If an interpreter passes the patient or family a box of tissues and even sheds a tear themselves, that's okay, because you're a professional member of a team. You're not just a robot on TV shifting the words back and forth. And when the acceptance at the end, patient might still see, we want to do everything for her. We don't say, no, we can't. We say, we're going to keep doing whatever we think will be good for her. We'll do our very best. And even talk about things like spirituality. I've had patients say, wow, you mean a priest can come and see her in the hospital? That was the most important thing that happened on a couple of visits like that. Before we run out of time, there's a lot of trouble with the technical side of words. You're better, what does that mean? Cured or improved? Patients who don't like to use, had a real patient with breast cancer getting chemotherapy. She did not like to hear that word. She called it a shadow, a lump, a mass. If that patient was speaking Cape Verdean, what words would you choose? Health literacy and intergenerational conflict is something we see in all situations. We don't have time to talk about. Cultural difference in this, who do you tell this information? The patient or just the proxy or a group? Does the group include the patient? And there are huge cultural differences, and each situation is unique, and we need to figure out what is best for the patient and family, who makes the decisions and whatnot, demonstrating empathy. These are all kind of things that will make a patient and a family feel better, and particularly around issues of guilt. When that woman, that Haitian woman, says she doesn't want to live the rest of her life on a breathing machine and looks at her son, then she probably is happy that what she did is going to make sure that her son is not going to feel guilty as the one who let her die. And this son will feel better with less guilt. Instead of using words like, we're going to stop this, no more of that, we can't do that, she's not a candidate for this, we're going to remove, discontinue comfort measures only gee, when you say only, that almost always means not as good as the rest. So try to shift. I don't know if this breaks your ethical code, but we can transfer the same meaning by saying, we're going to do a better job at this. We're going to handle this differently. We're going to change. We're going to spend more time, effort, attention to X, Y, and Z, the paperwork, your will, the pain, etc. When the patient says we want everything done, we are doing everything that makes sense and will help the most. We're doing the best we can. Now we're going to talk about paperwork, healthcare proxy forms. That's the one where the patient says, if I lose the ability to make decisions and communicate them, this is the person I want to do it for me. And advanced directives is a different thing. It's the, this is what I want and this is what I don't want. We're going to take a look at what those forms are like. I can't tell you that how good this, how much this helps documenting the patient's wishes, and preparing for a good death, reducing family guilt and stress. And even things like dying at home, we talked about returning to the home country, and if we had more time. And I'll show you what the advanced directive form allows the patient to do. We're almost out of time. It allows you, when they're unable to make their own decisions, it can tell you who they want to, well, what they want to happen and what they don't want to happen. And the healthcare proxy is who they choose. Here's the form in Massachusetts. So I pick so-and-so, I pick my spouse, my oldest, you name who you pick to be your healthcare proxy. There can be an alternative as well. And you can say to that person that you pick, you make the decisions about what to do, except I never want this. I never want to be cremated. I never want my body parts donated, et cetera, et cetera. So the healthcare proxy will not feel guilty with things that you said, or when I say you, I mean the patient. I feel like I'm talking to the patient. The healthcare proxy will do what you said, and they won't do what you told them not to do. This is a legal statement that has to be witnessed, and these forms are different in every state, and they should be in Massachusetts. They're available in these other languages, and the forms, one of the witnesses needs to be the professional interpreter for that language. We're almost done. Don't worry. We'll have time for questions. So the advanced directives is different. We just talked about the healthcare proxy. This is the medical orders for life-sustaining therapy. We call it the MOLST. In the old days, it was basically do everything or not, intubate me or not, put me on a breathing machine or not, do CPR or not, et cetera, et cetera. Transfer me to the hospital or not, a little bit different. And the back sheet of the form basically says things like, if you think you can keep me going and intubate me or dialyze me or put a feeding tube in, you can do it for a short term. But if it doesn't work and it's not going to work, I want you to stop it. Putting this in writing, showing the patient, okay. She said it was okay to intubate her, but she doesn't want it permanently. And we can even document the fact that the patient hasn't made up her mind yet, or that it was not a good time yet to discuss this. And this is a legal document that has to be signed by the patient and the clinician. And by the way, the versions of these forms in other languages need to go home with the patient. The patient should go home with copies of these documents in their target language. And hopefully every state and every country will eventually have these, so you don't have to translate all this fine print. The official version of this in America is the English version. That's the one that stays in the patient's chart. But we should give the patient and family more than that. All right, we're almost out of time. Gee, I thought we would have time to figure out the meaning of life. That's kind of tricky. I wanted to know everything you thought about life after death, reincarnation, redemption, punishment, sacraments, rituals, funerals, and how the patient wants to be remembered by their community and their family. and how they can make that clear to the clinical team and to the family. I'm going to make this very short. This was a huge study and very strange result. It showed that when professional interpreters were used and this was 2009, quite a while ago, when in ICU family conferences, that they were shorter by 18%. And they were shorter because the doctors like me talked only half as much. We made fewer statements that provided support for the family, and the family got less information, less emotional support. Hopefully, well, not hopefully, this is something we are ethically required to fix. We can't do this anymore now that we have what we need to make these good. The National Survey of Professional Interpreters 10 years ago said that only half of them felt okay with issues like this. And those were the people who felt that their roles were clear. The people who felt that their roles were not clear, that didn't have that pre-meeting, only 11% felt that these conversations went well. And 80% of these interpreters wanted to learn more about these end-of-life discussions. And that's why you trainers are here, to think about it and help them think about it. We're out of time, Analia. I know I talk too much. I try to listen.
No. This has been amazing. Dr. Hardt really wanted everybody just to take a second to look at Mahatma Gandhi's quote. So before he stops sharing, if you can just take a moment just to look at it, ponder on it. Dr. Hardt, we have had over 100 people today. We have so many questions, over 20 or 30. We will not have time, ladies and gentlemen, audience, everyone. I wish we had the time to answer all of the questions. We'll have to just choose a few of them, but I felt that it was critical that we got the entire presentation today from Dr. Hardt. Dr. Hardt, what about if you stop sharing? That way you can look at me and I can look, well, I can see you, but that way you can also look at me. You just go to, yes, stop sharing. Oh, you disappear.
Oh, wait a minute. Okay. I'm not very good on computers.
No worries. There you go. Awesome. Okay.
And if you let me talk for 30 seconds, Analia, I'll say,
yes.
That Stages of Grief in America from 1969, I can imagine in other countries that would be considered crazy. Anger, denial, all that. So those of you who are in other countries, other cultures, other customs, other traditions need to think about. And one of the strangest things I ever read in an article about cross-cultural grief written for doctors, it says, quote, advice for doctors: consider talking with someone who shares that cultural background or searching for information on the internet to learn more about customs and the mourning practices of a person from another culture. I think that's ridiculous. That's your job as a professional interpreter in these situations to say, wait a minute, Eric, no, you should call me Dr. Hardt in that situation. Do you understand what we do in our country, among, X, Y, and Z religion or whatnot? We don't even talk about this kind of thing. This is the way we do it, okay? That's part of the pre-meeting. And I don't have to go Google it to try to figure out how people like to die in your home country. All right, I'm speaking in a few extra comments.
No, that's okay. Let's go ahead and let me choose a few. And ladies and gentlemen, let me preface with this. Dr. Hardt, an amazing human being, he even said he won't leave at 12:30 Eastern time. He will stay on to answer a few more questions. But for those that need to leave at 12:30, please feel free to do that. So let's go ahead and start with one of the questions. It says, can we get a link to Dr. Hardt's research as it relates to interpreters needed in the medical field?
It's number one, it's very old research. I'm not a professional researcher. What I did was come up with an idea. And then I would go to people who knew how to do research and help them design a research study. And then I get the results of that study and I would use it to advocate for your profession. I worked with Tony Windsor when no state required professional interpreters present in any situations. So basically went to the emergency room, people that I knew there, they did a study showing that when people came to the ER with headaches and belly pain and chest pain and whatnot, we wasted money. We got lousy results. The patients were more likely to come back to the ER with the same thing. They were less likely to show up at the clinic appointments that were made unless we used a professional interpreter. We say, and the key thing, I took it to Beacon Hill and I showed them, we save money. You know, people are resistant to requiring interpreters because it costs something. Well, it's free, I told them on Beacon Hill, because you save more money as taxpayers than you spend on that interpreter. And a bill was passed in Massachusetts, the first one in America, that required professional interpreters. Now, that was only in emergency rooms and psychiatric units, but that obviously is generalized. There's a huge amount of research, and the old stuff that I was involved in is not as important as the newer stuff. So
okay. Your stuff is very important, but let's move on with other questions. It says, how do we convey wishes and how to advocate for the patient who is already suffering from senile dementia, yet does not have designated power of attorney to protect their interest?
And this is why somebody is 65 years old, playing golf, retired, there's nothing wrong with saying, hey, George, have you seen this paperwork that people do? It's called the healthcare proxy, advanced directives, and then explain to them what that is. Give them the paper, take this home, show it to your family, you know, talk about it. Let's talk about it more next time you come in to see me. You can fill it out if you want, and I'll sign it if that's the way you want to do it. So, and then 5 years later, when they lose the legal capacity to make their own decisions, we can look at the paperwork that their patient wishes that they expressed to us when they had capacity. It's the same as writing a will. If you want to say, I'm leaving everything to my oldest daughter instead of my oldest son, you can say that while you have capacity and put it in writing as a legal document, and then it will be respected even by your son.
Wow.
So we have to do this before, when we know that you're losing cognitive function, then it makes it a little bit more important. Think about this, put it on the table, start a conversation that goes on over time.
Thank you very much. Okay, another question. Does a patient receiving hospice care continue to have follow-up visits with a medical doctor? If so, is it an MD associated with the hospice facility or their PCP or something else?
And the answer is yes. If you're a good primary care doctor, as they all should be. I've got to convince medical students to do this. That your doctor, who's known you for 20 years, is a doctor in charge of your hospice work. If that doctor either doesn't feel qualified to do it, doesn't want to do it, or doesn't even exist, then the medical director of the hospice is the MD that does prescriptions, decisions, and is in charge of your case. So you will have a physician who knows what they're doing, whether it's your pre-existing primary care team or your hospice team, to carry out your wishes and do their best to provide a good death. Death is not always, almost all of us die at least once. So we can't consider it a failure if we do it the best possible way.
Okay, I have to tell you this, Dr. Hardt, and people just hear me out, because I was taking notes and I had never heard anyone say that we could have a good death. And I loved how in your presentation, you elaborated about how the healthcare team can aid and support that dying person to have a good death. It will depend on what the circumstances are, but I believe that the work that we do in the healthcare field is just invaluable. Anyway, I'm taking time
And
from the
now I got to
participants.
respond to that. I got to respond to that with one of my, at the home of a patient of mine who was taking his last breaths while listening to his favorite music, Georgia on My Mind, and 2 daughters and a son were there. And as the tune ended, he took his last breath. And I looked at his son and daughters and I said, this was the best gift you possibly could have given your dad.
Oh, wow.
And
Wow.
they
Dr.
looked at each
Hardt.
other and felt good. That was a good death. He died right in his home with his music, with his guitar by the bed.
Wow. Oh my gosh, Dr. Hardt, thank you. Okay, before we proceed, it is 12:30. I do want to thank the over 100 audience participants today for joining CCC. We believe that the work that you do as interpreters is invaluable. And we are so thrilled that we can be participants in assisting in your continuing development, your continuing education process and growth, and that you chose 1 hour of your day, of your life to be with us. So I just want to thank everybody, let you know that you're free to go. We're going to stay here for another 10, 15 minutes at the most, but you're free to go. You will receive your certificate of completion within 24 hours. Please, a reminder, download your certificate right away. Make it a ritual. You get your certificate, you download it, because I know life happens and we forget, and you will only have 3 weeks to download your certificate. We cannot procure another certificate for you. So I will say it again, download it right away. Okay, thank you everybody for joining us. And now, because of Dr. Hardt, just so gracious, he's going to stay with us a little bit longer. Okay, here comes another question, Dr. Hardt. When it comes to advanced directives, palliative hospice care, is it fair to say that an interpreter needs to be aware and use a combination of roles if necessary, interpret, advocate, and mediate? If so, how do you manage the flow of communication in these cases?
Well, remember that we collaborate in managing the flow of information. So if the son and the daughter are fighting over how daddy or grandpa wants to leave this world, I'll look at you and you'll look at me, and I'll start saying stuff in English and you'll start doing it in Cape Verdean. And you both, I can tell you both love your dad. No wonder you feel so strongly. He probably doesn't want to see the 2 of you fighting. So let's calm down and think about it, and we'll continue this conversation. Hopefully not in a crisis. Anytime you want to talk more about this, let's talk more about it.
Okay, thank you. Let's continue because we have many questions. Are there interpreters that specialize in palliative or hospice care? If so, how do you find a job in that area?
And I'm glad you asked that question. You know, I used to be a medical director of a hospice till the for-profit company bought it. But can you imagine? We used the hospice that I worked with. We were told that the Chinese and the Puerto Ricans didn't use hospice, nor did the Black people. Then I said, let's open up an office in Roxbury. And a Black woman ran our meetings, and we hired hospice nurses who spoke Spanish and Chinese. And all of a sudden, we had tons of normal referrals to hospice from those communities who previously were stereotyped as not using it. So if I were running a hospice now in a community, in a place like Boston, where we have a linguistically diverse community, and you were somebody who could show me that you have training, you understand the end of life documents and the expression of empathy and management of conversations and whatnot, I want to hire you full-time in person. Part
Oh,
of my team. And anytime the nurse or the doctor or the social worker makes a home visit, you should go with them.
yes,
Or at the very least, you could be there on video, but it's you. It's the interpreter that family already knows, not just
yes.
someone they've never met before and will never see again, who's sitting up there in Idaho or something. That doesn't do the kind of help that you can do when you're doing a job. And again, like I said, when I became a doctor, geriatrics was not a subspecialty. But when it became so common, you got a certificate in geriatrics. I predict eventually professional medical interpreters will get specific training and will be identified as a pediatric interpreter, psychiatric interpreter, geriatric interpreter,
Wow.
palliative care interpreter, etc.
I
And
surely hope so.
when you have a license, you'll get your salary will double.
Yeah, oh, absolutely. I'm looking, I cannot find my reactions, but I just wanted to give you a heart over here, Dr. Hart, because what you're doing, and you're saying, oh, my glasses, is amazing. So, oh, you're getting hearts from people. I love it. Okay. And one more thing that I will tell everybody, this is just something that I say to the people that I care about, is that always give, no matter where you're interpreting at, what the situation is, give 100% of your best. And I don't mean just the utterance, I mean your heart, your devotion for the profession, because people, you never know who is watching you. And because of what they saw in you, they may say, you know what? We need to refer this interpreter to this case. And it may open doors for you. Okay, a few more questions here. What is the best way that providers should let patient or family member know before accept to speak with a palliative care or hospice? Since a lot of Vietnamese patients mostly not understand those services. So this is talking about cultural issues, but I'll ask the question again. What is the best way that providers should let patient or family members know before accept to speak with palliative care or hospice?
And again, I don't like the expressions that medicine uses. Taking a history. Analia, if I met you in a bar and I said, oh, excuse me, I'm going to take your history, it smacked me in the face. Or if I said doctor's orders, as though I were a military general. So my feeling is back down a little bit. If the family doesn't understand, then let me explain to you. You know, in America, we have stuff like this. Boom, boom, boom. Explain what palliative care consult is. Explain what hospice is. And then, you know, you don't have to go on hospice. That's only for people who know that they're near the end within 6 months. But even as soon as you start struggling with this disease, the palliative care consult can help you deal with other issues. And it's up to you. It's your call. Do not force it on them. I'm going to enroll you. No, I'm going to make the consultation. Is that okay? Yes or no? No. Explain it, put the information on the table, and let the patient collaborate in the decision making, particularly for underserved populations. Sharing the power of the decision making is the way to get the right decisions.
And Dr. Hart, I had never heard this, but you shared about how you learned that in homeless shelters, in prison facilities, besides the VA and the nursing homes, that they offer hospice care. It's just beautiful. It's just the human thing to do. And when I heard that, it's like, wow, this is what we need to hear, that there is
Remember,
good in
it's
humanity.
not all prisons, it's not all VA hospitals, and it's not all shelters, but it can be done. It is being done, and we need to make it the routine common.
Exactly. Okay, let me see what else I can find here. There was a question. Let's see. One of the questions was that there is not the definition for the term hospice in Russian. What would you suggest to do?
Well, again, if the doctor or the team is using a word that does not exist in the target language, you have to figure out what words to use to convey the meaning. Explain to them. They call it a hospice in America. Say that in English, and this is what they're talking about. This is what they do, and this, you have a choice for that, et cetera, and listen and answer questions, which helps. So there's, if we had another hour, we can talk about, when I say you're better, if you had a cold, Nalia, and came to me a week later and you felt fine, I said, you're better, meaning you're cured, go back to work. But if you're a patient with cancer all over the place, and I'm giving a lot of chemotherapy, and then the patient or family, how's she doing? She's better. The nonverbal tone of voice, pace, whatnot of the same word means not worse, improved.
Yes.
It doesn't mean better, doesn't mean cured. So the more experience you have working as a professional interpreter, the more you'll learn, even by accident, those post meetings. When you said she was better and I told her she was, the word we use in English, in our target language, they take it as being cured. So I had to explain to her. That's why I talked so much when you told her that she was doing better. I had to explain that he meant that she was improved from the last time he saw her, but that doesn't necessarily mean the disease will go away, has gone away completely. I don't care how long it takes you to convey the meaning. With your expanded role on my team, do it.
Yes. Thank you, Dr. Hardt. Okay, more questions. We'll take just one more. It says, how do medical practitioners handle the situation when the family says that the death sentence or bad news should not be communicated to the patient? Back home, the practice was that the families told the bad diagnosis and expected to tell the patient when a good moment comes, and many die never knowing what they had. It seems wrong that the patient is not in charge of how they spend their last months of life.
And that's a great question, and I don't say that a lot. There are some cultures where the normal customs and practices are that you don't have to tell grandpa that he's dying of his cancer and it can't be cured. And that's the standard. And as I said earlier, in America, the young doctors are taught that the patient has to know everything. And I explained to my trainees and I've had debates in public in large audiences with lawyers, and we came up with a compromise that the patient has the right to know everything, but they don't have to be told everything. And the doctor has the responsibility to do what's best for the patient. So, like I said, if I, instead of, should I tell you this, yes or no? No. Ask open-ended questions, like, what other questions do you have? What can I explain to you, etc. And when the patient doesn't ask anything, they say, my family is so good, they're handling everything, I love them. Then, okay, you can shift to the family, tell all of them, and let the family know that if she ever asks you that question, when I'm alone with her and an interpreter, I'm sorry, my ethical code says I have to answer her question, but it's okay if she doesn't know, if that's the way your family wants to handle it.
Okay, so Dr. Hardt, I have to tell you something. Somebody just posted, please ask Dr. Hardt back and give him more time. This was a wonderful presentation, and we all need to hear more from him. Thank you, Dr. Hardt.
I got so much positive feedback in the chat room there, but no one talked about how handsome I used to be.
Oh my!
Or even how good I look now. Come on.
Ladies and gentlemen, before we close, I have to tell you, I didn't know that Dr. Hardt was the handsome man on the video. I didn't know that until an hour ago. We're so grateful to have you, Dr. Hardt.
Thank you. I can leave now. And I'd love to be back with everybody on this webinar and more, and we'll talk about other geriatric issues.
Dr. Hardt, I will certainly send you an email today, and then we'll make another time in Zoom to talk about 2025, right? We need to have you back in 2025.
And remember, you have to pay me for this talk by sending me a pizza with extra cheese, not pepperoni.
Ooh,
My wife
no,
would reject.
let's meet in person. Dr. Hardt, are you in Boston, Massachusetts?
Yes.
ATA is next year in Boston. You gotta
Okay.
come. We can meet in Boston, Massachusetts, and I'll treat you for pizza with extra cheese.
And I'll pick the beer, usually a Mexican Tecate.
Okay, that's okay. That's okay.
Okay.
You're awesome, Dr. Hardt. Okay, ladies and gentlemen,
Thank you all.
we
Appreciate it.
thank you so much, everybody. Thank you, Dr. Hardt. We're
You've
so
made me happy.
grateful. No, you
Bye.
made us happy. You made us happy. Everybody,
It goes both ways when it works.
thank you. Thank you. Okay, everybody, thank you so much. Have a wonderful rest of your day. Thank you for joining us. And we'll see you. Well, happy Thanksgiving, and we'll see you next month. Thank you, everybody. Bye.